It's good. So I know almost all of us met Dr. Aldiri yesterday, but just to introduce him again, he is a medical oncologist and groundbreaking researcher, professor of pathology and laboratory medicine and associate dean for oncologic sciences here at Brown. He's also the director of the Cancer Center at Brown and the director of the joint programs in cancer biology here. What I didn't mention yesterday is that he was previously a deputy director of the translational research at Fox Chase, where he co-led the molecular therapeutics program. And he's actually is among the 40 most cited researchers in 1990, with 13 of his papers receiving over 60,000 publications and another over 9,000. And we kind of heard sort of a little bit of this, but I don't think I did a good job of identifying this, but he has identified the genomic DNA findings associated with P53 and then identified the WAF-P1 protein, which he described yesterday, as well as the trial death receptor, which we learned yesterday reduces apoptosis in vivo after exposures in gamma radiation. He has completed MD and PhD degrees from the University of Miami, as well as internal medicine residency and oncology fellowships at Hopkins. And we are really excited today to learn about liquid biopsies, Dr. Aldiri. Thank you.
All right. Thank you so much for inviting me to tell you a little bit about what I know about liquid biopsy. What I hope to do today is give an overview of the field of liquid biopsy as it relates to cancer detection, therapy, and disease monitoring. And this is an exciting and evolving field. I'm going to give you a flavor of what is going on in the laboratories, as well as in some clinical trials. We're all learning, and putting this together was a good opportunity for me to bring some things together. And there are many opportunities with liquid biopsy. So it's a good area to try and be creative and innovative. So these are my disclosures, and I will let them stand there for a few seconds for you to look at them. Nothing I'm going to talk about today relates to anything I'm showing here. Okay, so let's begin with a definition of biomarker. A biomarker is a biological molecule found in blood or other body fluids or tissues that's a sign of a normal or abnormal process or of a condition or disease. A biomarker may be used to see how well the body responds to a treatment for a disease or condition. And it can also be called a molecular marker or a signature. And sometimes markers are combined to provide more specificity or more insight into biology or clinical relevance of a measurement. This is taken from a review that Anna Louie, who's a surgery resident at Brown, wrote a couple of years ago. And it's a good opportunity to bring out different types of biomarkers and their clinical utility. So we have diagnostic, prognostic, predictive, and pharmacodynamic biomarkers. And you could sort of look here at use. First, what is predicted by the different types of markers. Perhaps it's good here to focus on diagnostic as it might relate to screening, early detection, and cancer prevention. So a diagnostic biomarker would be expected to detect the presence of disease. You would hope to do this before the disease became obvious. And of course, this allows screening of healthy individuals who may then ultimately benefit from the screening because their disease is detected early. So this is also taken from that review, and it sort of captures some of the clinical utility of biomarkers in terms of the type of data, and we'll talk more about these different types of data. Of course, we're in the age of artificial intelligence, and there are many opportunities for that to impact on the analysis of the data and ultimately how it relates to disease outcomes. With regard to the timeline and opportunities for utilization, again, if you look back here at diagnostic biomarkers, these are going to be useful for screening healthy individuals and prognosticating or maybe helpful in making a diagnosis of in this case, cancer at an early stage where some sort of intervention might lead to cure, whereas later detection would be at a more advanced stage with less of a chance for a cure. So in the field of oncology, biomarker testing offers a way to look for genes, proteins, different substances, and we'll talk more about this, that can provide information about cancer. Every person's cancer has a unique signature, and some biomarkers might tell you something about how well treatments might work, and other biomarkers might help you choose a particular treatment for a patient. You hear about companion diagnostic, and often drugs are approved by the FDA for targeted genetic mutations in tumors, and they come with companion diagnostic that will then select the patients for that appropriate therapy. So circulating biomarkers can be used in different ways. They can be used as a correlate of tumor burden. They can detect residual disease or relapse. They can tell you how well treatment is working. They can monitor whether treatment has stopped working. Serial measurements are known with older biomarkers, but they're now being looked at with some of the genomic circulating biomarkers, and I will speak more about that. Another area which perhaps is relevant to survivorship would be periodic measurements of biomarkers off of therapy well into the future to check for recurrence. And frankly, with the use of liquid biopsies and blood-based biomarkers, they're easier, cheaper, faster, less exposure to radiation as far as CAT scans and so on. And so this is something that is really happening as we speak and is being understood and studied so that we could use it more in clinical practice. I think all of you would be familiar with these classical circulating tumor biomarkers whose levels are increased. I guess I didn't put PSA on the list, but you know, these are markers that could sometimes help with diagnosis. They can certainly help with disease monitoring for various tumor types. So I was featured on the cover of Hem/Onc Today on the December 25th issue, basically for the lead article about liquid biopsy continues its evolution in cancer care. There's a lot more to the article, but these are some of the things I was quoted as saying. And you know, on the front page right over here, it says, oncologists need to learn about how information derived from liquid biopsies can be used in treatment of specific tumor types. A lot of people in oncology are not aware of how powerful this technology is. So there are a lot of nuances, there are a lot of technologies, there's a lot of different uses of the liquid biopsies, and we're all learning and trying to figure out how to best incorporate them into our clinical practice. And of course, the guidelines are lagging behind as we're all still learning about the optimal use of biomarkers. So let's talk for a minute about what is in the blood. I have a couple of different versions of this, but essentially liquid biopsy, you can measure many different things, okay? You can measure circulating free DNA, circulating free RNA, microRNA, you can measure various proteins. TEP is kind of interesting. I saw that. What the hell is that? Tumor-educated platelets is what that is. Circulating tumor cells, exosomes. We have local expertise in exosomes over at the Coro building with the work of Dr. Quisenberry and his colleagues. And these are vesicles, essentially, that are expelled by both normal and tumor cells and contain signatures. And you can measure many of these other types of things that are freely circulating in the blood. They can be within either circulating tumor cells or platelets or exosomes. And then the things, the usual things that are in the blood. And this is obviously in addition to classical tumor markers, the various antigens I was just showing you, and metabolomics, circulating metabolites, and that area is still further behind in terms of its utility here, but certainly continuing to evolve. I'm going to talk a bit more about technologies in upcoming slides. It's important to remember flow cytometry, which basically puts cells one at a time through a laser, and you can detect multiple different markers on individual cells, very commonly used in the liquid tumors, and really a very powerful technique. Now, some of the newer technologies and techniques are shown here. Bulk cytokine profiling is possible on clinical samples with instruments like the Luminex 200, which is shown here. I have some description of how this works here, but basically you can multiplex many different markers. So here at Brown, for example, we have a setup at the medical school where we can detect over 60 cytokines, chemokines, growth factors that essentially can correlate with disease. We did some of this during COVID, and the pattern of cytokines was put through an algorithm by Dr. Louie, who I showed you wrote that review earlier. And we were able to recognize features of macrophage activation syndrome associated with severe COVID when these blood samples were taken from patients in the emergency room. Now, on the right is a platform called Isoplexis, and we brought this for the first time in Rhode Island over the last year, and it essentially allows you to get single cell cytokine profiling, and you could get a readout on innate or adaptive immune system cytokine production. And these are some of the applications out there on the field. There is this concept of polyfunctionality, the number of cytokines a single cell will produce, and that can be altered in different states, or you may discover sets of subsets, for example, here with CAR T cell therapy, alterations in IL-17A, producing T cell subsets correlated with anti-tumor function, but also predicting acute cytokine release syndrome and neurotoxicity. This is a capability that allows isolation of circulating tumor cells from patient blood samples. So you could see over here is the blood, over here is a buffer, and then they go through a chip, which is in here, and off over here comes the red cells, off to the right come the white cells, and down the middle come the tumor cells. We have this set up at the medical school, and it works by the principle of negative selection, so that the red cells and the white cells are selected for, and everything else goes in the middle and can be collected, and you can do things with it. And so one of the good examples was a paper published a few years ago by Dan Haber, who's head of the Cancer Center at MGH, showing some of the things you can do with ex vivo culture of circulating breast tumor cells. And I'm just going to go through some of this just to give you a flavor of what's possible, because it's truly incredibly powerful technology. So you can isolate tumor cells, you could look at their markers. So cytokeratins will highlight cells of epithelial origin. Ki-67 highlights proliferation. CD45 highlights immune cells. And you can get these cells to grow in culture. You can grow them in mice and image the growth. You can then look at different markers and relate them to the patient's primary tumor. These are some mutations that were detected in cultured circulating tumor cells from various patients with breast cancer, as you can see here. And some of what can be done with these cells is also truly amazing, which is drug sensitivity testing of the cultured circulating tumor cells against panels of drugs, so you can determine the mutations, you can test various against various drugs. And if you look at the list here, it's certainly relevant to breast cancer, and you can get readouts on cell viability from the patient's actual tumor cells. Then you can also consider combinations of drugs and evaluate their sensitivity based on the patient's own profiles. And the tumor cells can also be grown in vivo and looked at with those very same drug combinations. And so this is incredibly powerful, and it's very futuristic, but definitely feasible, and something to look forward to seeing more of being implemented into clinical practice. Genomics should be mentioned, this is classical genomics from a biopsy of a tumor that can then be analyzed by DNA sequencing and by comparison to reference genomes, and one can then determine therapy based on the genomics of a tumor. today's talk is about liquid biopsy and how we get some of that information out of the blood. One of the technologies that is exciting that's here already is spatial transcriptomics, and this is the ability to have multiple sections and look spatially at these arrays for a specific expression of genes in essentially three-dimensional space. So this is here now and is already being used, for example, to look at what happens to immune cells when tumors are treated, or when tumors are going to respond or not respond to treatments. So I thought this would be a good opportunity to share with you some of what's possible here at Brown in terms of creating organoids from patients, either normal tissue organoids or tumor organoids from the circulating tumor cells, kind of putting them through some of these technologies for analysis, and simultaneously using mouse models to interrogate the impact of the genetic alterations that drive specific tumors in terms of how they respond to treatments or how they respond to immune cells. So, there are lots of different uses, including drug efficacy and toxicities, and learning about the cytokines is a great way to gain insight into the biology and the therapy, and lots of different applications. So this is a reminder that liquid biopsy isn't just about blood. You can get saliva, you can get urine from patients, and you can measure some of these very same things, and people are doing that. And again, just to show you in a different representation, the types of things you can measure in a drop of blood. You can look at circulating tumor cells, these tumor-educated platelets, exosomes, and then the nucleic acids, which we will talk more about. So talking about circulating tumor DNA, it's in the blood, it comes from tumors, and some of it comes from tumor cells. Most of the DNA is in the nucleus, but as the tumors grow and the cells die, the dead cells kind of shake off, get into the blood along with their DNA, and they're detectable in the blood, or at least fragments of the DNAs are detectable in the blood. ctDNA quantities vary depending on the type of tumor, its location. There is a correlation with tumor burden, but proximity to blood vessels is one of those variables. And the range of uses include early detection, monitoring treatment response, identification of recurrence, resistance mechanisms, potentially identifying targets for treatment that maybe the patient hasn't been given, and monitoring tumor evolution, and I will talk a little bit more about those. Now, let's go back about 3 years, and ASCO had a special article in the JCO looking at circulating tumor DNA analysis in patients with cancer. ASCO and the College of American Pathologists reviewed things at that time. That's 5 years ago now. And you could see in their abstract some of what they conclude here, including that ctDNA is optimally performed on plasma collected in certain types of tubes. So they were looking at best practices. Some ctDNA assays have demonstrated clinical validity and utility in certain types of advanced cancer. However, there is insufficient evidence of clinical validity and utility in the majority of ctDNA assays in advanced cancer. There is discordance of results, or there can be discordance of results of ctDNA assays and genotyping of tumor specimens, and we could talk more about that. Some of it has to do with the timing of the tissue versus the blood sample, and early studies sort of looked at up to 2 years. And generally, the further apart they are, much greater the likelihood of discordance, because many different things may be going on in terms of the status of the tumor. At this point in 2018, they were saying there's no evidence of clinical utility and little evidence of clinical validity of ctDNA assays in early stage cancer, treatment monitoring, or residual disease detection. No evidence of clinical validity or clinical utility to suggest that they're useful for cancer screening outside of a clinical trial. I would still agree with that, although the tests are now readily available, especially to people who can pay for them. So they are certainly available outside of a clinical trial. And given the rapid pace of research, you know, they will reevaluate. They haven't yet, but anyways. So this is here for you to look at in terms of some of the definitions we spoke about. We didn't talk about variant allele fraction, but variant allele fraction, and I'll show you an example later, gives you a sense of how much of a variant or mutant DNA is present in the blood. If it's heterozygous, it would be up to around 0.5, you know, half the DNA, and if it's heterozygous in the germline. Often we will see these variant allele fractions that are quantifiable in serial monitoring from patient samples, looking at specific mutations in genes, and watching those changes as a function of time with therapy. And this includes the emergence of resistance to therapy. So, you know, the key findings are here for you to look at your leisure. They were summarized in sort of the skeptical tone of the abstract that I showed earlier. Now this is important to look at here, just because we have ctDNA, we have tissue assays of tumors, and it's not either or. I think the field, and one of the things we talk about in this Hem/Onc Today news article is these are complementary tests. They're not mutual, it's not either or. You know, in terms of logistics, I think I've mentioned the advantages of the circulating tumor DNA. With the tissue biopsies, you know, they're certainly more time consuming, more invasive, and serial testing can be very difficult. The biology can be different. So with a tissue, you get what you get where you stick the needle. With blood, you get a sampling from the whole body, essentially. And so you can sample that heterogeneity in a patient. And so that's one of the things that makes these complementary. Also, the serial testing and the ease with which the blood can be done makes it feasible in the future to do multiple blood tests after initially looking at both tissue and blood. You know, at the time of this review, there was limited evidence for the utility of the ctDNA assays. And also in this review was this depiction of true positives by either test, and you could see that they're not perfectly concordant. Sometimes you find things in tissue, and sometimes you find things in blood, depending on the sampling. And some of the sampling from the blood might pick things up that are at metastatic sites where you've evolved a mutation, but it's not part of the tumor that was either resected or biopsied. And then there's this thing called clonal hematopoiesis, where in all people, especially as people get older, there are mutations that happen in the blood that could masquerade as circulating tumor DNA. And this has ramifications in terms of the technology that's used and the controls and the interpretation of exactly what is being detected and measured, and you should be aware of this issue. So I'm gonna keep going here. So some of the things that have been happening, so I found this nice review about, published a year ago in Science Advances, one of the science journals, about monitoring and adapting cancer treatment using circulating tumor DNA kinetics, and to give a flavor of what is possible and what are some of the things that are being seen. And there are clearly kinetics to circulating tumor DNA as a function of things that are happening. So tumor is growing, a patient has surgery, and levels drop after surgery, but they may come back, and then patient gets treated, they go back, and then maybe the tumor relapses at a later point in time. And so there are different trajectories, from a response to outright progression when you're treating patients. Essentially, it's a tumor marker, but instead of, a CEA or a PSA, it's looking at a specific mutation. And then, one looks at multiple mutations at the same time, which is one of the things I'm going to show you. But there have now been studies that analyze ctDNA and treatment outcomes in patients treated with chemotherapy, and with predictions about changes in levels of ctDNA and predicted and essentially clinical benefit, partial response or stable disease predictions in different tumor types. Here, some GI cancers and lung cancers and ovarian cancers and lymphoma, et cetera, et cetera. But the evidence continues to build that these do have utility in predicting events that occur later. This review was thinking about clinical trial design going into the future, where, for example, you could think about enrolling patients into a trial whose ctDNA was either dropping or staying the same, where they may be randomized to continue what they're getting. So if the ctDNA is going down, you would continue until they progress, whatever treatment they were getting. If the ctDNA was not going down, you might continue until they have obvious progression, or you might randomize to an escalation of treatment, either to something else, or doing something different with the treatment to hope for a better outcome than stable disease, for example. And then de-escalation, if it's going down, you might consider de-escalating treatment or continuing to progression if it's dropping down. Whereas here, so these are just some thoughts about how one can incorporate some of the technology into design of clinical trials. And there are various trials that are ongoing, as you can see here. This is a case that I presented over the summer in Barcelona at a international tumor board. One of my patients at Lifespan who has metastatic colon cancer with liver metastasis and a bony lesion after he initially had a rectal mass on a colonoscopy for bleeding in just over a year ago. Not a particularly strong family history. The patient received these chemotherapeutic agents, as you can see here, and has, you know, these other comorbidities that have been picked up on PET-CT and MRI. And, you know, this was how this patient presented at diagnosis. He did have a response to systemic chemotherapy and then was put on maintenance therapy and was stable as of this fall. Now he had serial liquid biopsies, as you could see here. You could see the time of the biopsies, what was picked up, and this is how you can visually look at different different components of the liquid biopsy and how they changed with treatment over time. And then, so when he started getting his maintenance therapy, his ctDNA actually started going up. And this was over the summer in July. You know, so this was his variant allele fraction that I was telling you about. You know, these are the numbers up here. And his variant allele fraction went from like very low, but not zero, to something that's measurable. At that time, we looked for, you know, evidence of progression. He had a he had a PET scan and had a lesion light up where he had a lesion before. And so we considered giving him radiation therapy. But interestingly, the variant allele fraction went down. By the time we were getting ready to do it, it just went down by itself at that time. So that's some evidence of fluctuations. And later in October, it looked like it was going up a little bit, but it's no real evidence of real progression. And he continues on maintenance therapy after the slight progression actually diminished after that in subsequent testing. You know, experiences like this will be reported, and actually in the case of advanced cancer, one of the questions is, you know, when do you stop therapy and who's cured and so on. And these are going to be questions that we will be grappling with, especially, you know, it's very hard to explain what happened here in July with the increase of the tumor marker. You know, do these fluctuations occur normally? And is it true? I mean, I tend to think that it's true because the DNA that was picked up was mutated p53 and mutated APC, which is really what is driving this cancer. And so, you know, things like that do happen. And as you can see, it got better with no change in the intervention. Now, I wanted to mention something else that we're learning from liquid biopsy, which is very cool, which is, you know, there are these anti-EGFR therapeutics, and you start getting those, and then disease grows, and there are different mechanisms of resistance, such as RAS gene mutation makes tumors resistant to anti-EGFR therapy, or certain other specific mutations of EGFR can do this as well. So this is an example of a liquid biopsy in a patient, and when they progressed, the therapy was withdrawn. And the surprise was, they were getting some other therapy in here. And you could look at, in this example, something that didn't have a anti-EGFR agent. The driver of the resistance to the anti-EGFR agent actually extinguished with a break from anti-EGFR therapy. This is surprising. One wouldn't have necessarily expected this. And it almost suggests that the resistance mechanism was due to really the selection pressure with the therapeutic. And, patients whose markers of resistance extinguish have been re-challenged with anti-EGFR therapy and have had certainly partial responses before progressive disease. Before we could look at this in this way, if a patient progresses on anti-EGFR therapy, that patient wouldn't be re-challenged with anti-EGFR therapy. So this is one of the important insights that's coming out of liquid biopsy and circulating tumor DNA. I'm going to talk for a couple of minutes about circulating tumor cells. I mentioned them before, but circulating tumor cells are tumor cells that are shed from the primary tumor and intravasate into the peripheral blood circulation and are responsible for metastasis. They can be detected from clinical samples and can serve as an effective tool in diagnosis and prognosis through liquid biopsy. And you could sort of see this pictorially depicted here with tumor cells escaping, getting into the blood. And sometimes in the blood, they are in clusters or they're stuck to immune cells, and eventually they find their way to a metastatic site and they invade and start growing. And there are lots of different markers that are used to detect different types of tumor cells. This is a list of epithelial markers because most of these tumors are of epithelial origin. So you'll see EpCAM a lot. It's commonly used. Also, you can pick up mesenchymal tumors. Tumor cells in the blood tend to undergo an epithelial to mesenchymal transition, which helps them get into the blood and travel. And then when they get to a metastatic site, they tend to revert back to the epithelial state. And so sometimes CTCs will have both epithelial and mesenchymal markers. And this is the type of thing that can be done. It's done in patients with breast cancer, probably more than any other tumor type. And there is this cell search technology, which there are other technologies, but cell search is pretty old, and you can identify the CTCs using markers, and then you can do things with the CTCs. But in terms of what they mean clinically, they do have prognostic relevance and importance, and I'll show you some of that data. And then sort of the more futuristic type of molecular analysis and drug sensitivity analysis. So several years ago, this paper was published in the New England Journal by leaders in the field of breast cancer, and they essentially showed in a pretty large number of patients that if with metastatic breast cancer, if you had less than 5 CTCs in a 7.5 mil of whole blood, you had a better outcome than if you had more than 5. And anyways, this is more of the same. I think one of the important directions in the field for the future that I do want to emphasize is mechanisms of resistance and heterogeneity. And with evolution of the technology, we now have the capability of single cell analysis and single cell multi-omics. And, I watch this happen and I frequently ask the question, show me the clinical utility of this amazing capability of technology. I think it will come with time, but I think part of what physicians and physician scientists can do is to apply their knowledge to try and help with the clinical translation and sort of figuring out what to do with all of this information, because that's what it is, a whole lot of information. Now, I'm going to spend a couple of minutes reviewing some of the progress in precision oncology before I get to the MCED tests. And really, the goal of precision oncology is to get the right treatment to the right patient at the right time. So with genomics and all these other omics, but principally genomics, we find the mutation and then hopefully we have a drug to treat it. By the way, one of the biggest problems in the field is not enough drugs for cancer drivers, and but that keeps getting better over time. So you should be familiar with the MATCH trial. This is a huge trial that was conducted by the NCI and cooperative groups that enrolled 5,000 patients with cancer, and they had biopsies, and their objective was to determine whether matching certain drugs or drug combinations in patients whose tumors have specific mutations will effectively treat their cancer regardless of the cancer type. Now going into this a few years ago, they expected only about 1 in 4 patients to actually have something for which there might be a drug. So that, obviously not everybody has a targetable mutation. And this was a study schema here in terms of what would be done based on what happened with a specific targeted therapy. And so if they showed any sort of response or stable disease, they continued, and then ultimately they would check for additional mutations and continue in this trial. And this was open all over the country essentially, and this is that 24 treatment arms. These are some of the mutations and sort of their frequency, and some of the results that have been coming out over the last few years. So one is with patients with mismatch repair deficient tumors. Here in patients with multiple different tumor types and responses to immunotherapy, which was included in this trial, and you could sort of look at the waterfall plot. This one on the left is called a swimmer's plot, with how long patients ended up staying on therapy. BRAF mutated tumors of different types treated with dabrafenib and trametinib, and again the waterfall plot and the swimmer's plot. PI3 kinase, PIK3CA mutations, again in different tumor types. Now, another trial you should be familiar with is ASCO's TAPUR trial, the Targeted Agent and Profiling Utilization Registry Study. ASCO, our Professional Clinical Oncology Association, has started this trial several years ago. It was only clinical trial they have done, and it was a precision medicine clinical trial targeting molecular alterations in cancer. And this is sort of a diagram showing frequency of mutations. Guess what's all the way at the left here? It's P53, and going all the way to the right. And so a large proportion, it was predicted that a large proportion of cancers may contain at least one plausibly actionable genetic mutation. And the long tail means that conventional clinical trial design may not be feasible, and that doing this type of clinical trial would be helpful. And so these were some of the problems that were being addressed. What can we learn from this experience? One of the nice things about TAPUR is that it allowed liquid biopsy as a way to enroll patients, interestingly. So the idea was to learn from the real world practices and to educate about how to use genomically targeted drugs. And this is good for everyone, really, because we are providing effective treatments to patients. The other nice thing about this trial, which was also open all over the United States, I was actually the PI who brought it to Fox Chase when I was there. And basically, they convinced various pharmaceutical companies to just provide the drugs. So that made the drugs available for patients who enrolled in this study. And just a little more information here about eligibility, and interestingly, the FDA deemed them the treatment arms exempt from an IND because these were already approved drugs that were available, approved for some indication, but maybe not others. And typical treatment endpoints here for a phase 2 type of design, with the idea of enrolling some patients, and if they have very few, they'd stop. If they had at least 2 responses, they would enroll more. Just some more information about how it works and its milestones. And these are some of the treatments and some of the companies. Lots of companies, lots of drugs, some of the data that's been emerging. So pertuzumab plus trastuzumab in patients with colorectal cancer with ERBB2 amplification or mutations, results from the TAPUR study. HER2 is about 3 to 5% amplified in colorectal cancer. And although interestingly, they found the combination didn't help for mutated HER2 mutated tumors, but the ones that were amplified seem to be the ones that were benefiting. And some of this is known from other clinical trials in the field. We didn't really need the TAPUR study, except that this particular combination was the one that was tested here. Now let's talk about the MCED tests, and we'll wrap up. So the multi-cancer early detection tests allow early detection and diagnosis. And we know that early detection of cancer can significantly improve survival rates and also reduce the cost and complexity of treatment for screenable cancer. In fact, the overall survival rate of cancer is 4 times higher when cancer is found before it spreads. So interestingly, if you study cancer screening, we can't really screen for a lot of cancers. Like there is some screening for breast, cervical, colorectal, lung, especially in smokers who are at high risk, and prostate. But for many other tumor types, we really don't have screening tests that are used in the population. And these MCEDs are essentially liquid biopsies that complement other ways of screening and have promise. So, some of these are statistics you are already aware of, including the number of deaths from cancer each year and the difference in patient survival depending on whether the tumor is localized or metastatic at the time it's diagnosed, the costs of taking care of late stage cancer, and just expected costs over the next decade of cancer in the United States are quite high. And so these MCED tests are under development to essentially improve cancer outcomes, to detect cancer earlier. And obviously, there are issues with wanting to minimize overdiagnosis and false positives, and also psychological stress is obviously very important. But they are thought to give us a very good chance to impact on patient outcomes. And you can sort of see here a little bit more if there's an undiagnosed tumor and it's shedding DNA and it can be detected in the blood and so on, then you might be able to make a diagnosis based on that information, including what type of cancer it is. So the technology from a single blood test can tell you what type of cancer based on the types of analyses with machine learning classification, or maybe they don't detect anything. So this is a recent, it looks like this just came out in December of 2022. And I'll just show you some of the data in here because this is fairly up to date about, so first of all, there is something you should be aware of. It's, most of you have heard of the Cancer Genome Atlas, TCGA. So for a few years now, there is now a circulating free cell-free genome atlas, CCGA. Okay, then there's circulating free DNA. There's the MCED test. There's the tumor allele fraction. And then there are these machine learning classifiers. I should mention it's not just about mutations. It's about genome methylation is important. In fact, as you'll see, the methylation profiles are more sensitive. They're picking up tumors at much earlier stage. And here they conclude with the whole genome methylation feature best predicts cancer signal origin. So that's important, like where it comes from. But it's also the most promising technology from MCED, and is being further developed. So here is sort of their schema for the circulating cell-free genome atlas study, and they have different sub-studies. Some of this has already been published. This particular paper sort of went through these algorithms, as you can see here, in terms of what they ended up analyzing, and the numbers of tumors, and whether the individuals ultimately had a diagnosis of cancer or did not have a diagnosis of cancer. And one of the things here, the tumor allele fraction across some of these tumor types did correlate with stage of tumor when tumor was diagnosed. So, the circulating tumor DNA does reflect tumor burden, but also stage of cancer. And so this was one of the pieces of data they have here. The other thing in terms of sensitivity, you could look here at cancer stage, and this is across a training set and a validation set in this sub-study. And you could see, they are, you could see the percentage, the sensitivity, the percentage of patients without diagnosed cancer who are proving to have different stages of cancer. So you could see for stage 1 and stage 2 combined, you're getting up to the 40 to 50%, maybe a little bit less across cancer types. And this is important to recognize because this is a blood test, and a lot of these cancers going into this, there is no test. So you could say, well, that's just not good enough. But I think it is promising. And even if you look at stage 3 in patients without diagnosed cancer and the ability to pick this up, outcomes from stage 3 for a lot of tumor types are certainly much better than metastatic advanced disease. And here, it's certainly above 50% where you can make a diagnosis from a simple blood test. There are other platforms. One that you'll hear about is called Cancer Seek, where they're looking not just at DNA amplicons, but also protein panels. I will now just wrap up with reminding you that there are plenty of opportunities here at Brown to use the new technologies to look at cancer risk and cancer susceptibility, and to model experiments looking at interactions with the immune system, drug sensitivity. As I mentioned earlier, we are interested in multi-cancer early detection tests, and actually have a protocol under development, which is an investigator-initiated trial using an MCED test, which is essentially technology-enabled health equity pilot program at our cancer center, based on the hypothesis that we could impact on cancer screening mandates and recommendations through community outreach by providing screening in a more convenient, community-based, less expensive, technology-based methodologies. These types of interventions will address disparities in healthcare and lead to larger scale interventions in the future. So certainly a clinical trial. And we are collaborating with the fire department in Providence that has 400 firefighters, as well as we will enroll several hundred patients from various underserved communities around Rhode Island going into the future. So thank you for your attention, and I think I'll stop here and see if you have any questions. Sorry for running over a couple of minutes.
Thanks, Dr. Aldiri. That was really awesome. I'll open it up. I know Tamara had a question that she really wanted to ask, so I'll let her go first.
Hi, Dr. Aldiri. Thank you so much for the lecture. I'm still trying to grasp. I know you gave like a couple different examples, but I'm trying to grasp how ctDNA would alter the treatment course for somebody. I know that you had the slide where it showed that it could either lead to de-escalation of treatment or escalation of treatment, but I kind of wanted you to expand on that. I wanted to understand.
Yes.
How it
Yeah. I'd be happy to do this. So when I was at Fox Chase Cancer Center, I worked with several hem-onc fellows, and we actually published a paper in colorectal cancer with about, I think, 33 or 34 patients and their liquid biopsies. And it was about clinical utilization patterns in a GI oncology clinic at a cancer center. And, I can tell you, I often will see patients with advanced colorectal cancer who come, and there may be no genomics available, or there may be tissue in a pathology department that may be where it may be possible to get that tissue sent, but it's going to take you typically 3 to 4 weeks with tissue if things go well. With liquid biopsy, you can draw it in the clinic that day and send it, and you could have results within a week, if not earlier. So take colorectal cancer by example. Tumor mutation burden will show up. Whether they have microsatellite instability will show up. I've picked up HER2 mutation. I've picked up KRAS mutation, or BRAF mutations. We've seen BRAF amplification. We're not quite sure exactly what that means, but these findings that bring these types of mutated genes to light in a specific patient's tumor will tell us something about, if it's a right-sided tumor and it has BRAF mutation, you kind of begin to know what you're dealing with. Now, I think you will say, well, but what are you going to do differently up front? And the answer is, at this point, maybe not a whole lot, unless, of course, they have a KRAS mutation, in which case we wouldn't use an anti-EGFR agent. But with time, I don't think the studies have been done. For example, so BRAF is really bad and has a very 12-month survival, usually with a BRAF in colon cancer. But a lot of progress has been made with combining BRAF inhibitors with anti-EGFR agents. And I don't think the trials have been done as far as getting those types of therapies in the front line versus after they've sort of failed the conventional treatments. But that may change over time. Certainly with microsatellite instability up front. And again, it's like how quickly. Now you could say, well, when they made the diagnosis of colon cancer, they stained their tumor for the mismatch repair proteins, and you kind of already know, even without the liquid biopsy. Yeah, that's true. But sometimes you don't even have all of those results. And now, if you have a patient with metastatic colon cancer and they have microsatellite instability, the frontline therapy is immunotherapy. It's not chemotherapy. So you really need to know, because it matters. And sometimes, very elderly patients may not want chemo, and immunotherapy is not so toxic. I've been treating 87-year-old woman for a couple of years now, and she's been doing very well with immunotherapy. So, I don't know if that partially answers the question. I think certainly with serial monitoring, we see mechanisms of resistance. We quantify the tumor. So I should say, in several different tumor types, a good number of patients don't make tumor markers that you could follow, whether it's CEA or otherwise. And so for those patients, you're sort of stuck with doing scans whenever you're going to do them. And but now if you have a liquid biopsy, you do have a tumor marker. And I should say, I think we all need to be educated about interpretation of these tests. So when I look at the results of a liquid biopsy from a patient with colon cancer, I'm not just seeing, do they have it and how much. I'm looking to see what type of mutation is it. Is it known to be associated with colon cancer? Do they have the constellation of P53, APC, and maybe with or without RAS or BRAF? And when I see those, that's not clonal hematopoiesis. You're just not going to, if the variant allele fraction for 3 different mutated DNAs are similar in a patient sample with advanced disease, I'd love to argue with anybody who would say, yeah, you better be careful, that could be clonal hematopoiesis. But in any event, there are now companies that do the testing on normal cells, and this is still an emerging area. I should say that with clonal hematopoiesis, a lot of the mutations are not in colon cancer inducing genes. They're in STATs and other genes that may be related to MDS and more biology of hematopoietic cells. But it has been documented in at least one patient somewhere that they had a RAS mutation that was from clonal hematopoiesis. So I'm not going to say it cannot happen, but the frequency of that as clonal hematopoiesis is extremely low, and
So what, sorry, it's not clonal hematopoiesis, then what is it?
it's tumor DNA.
Just tumor DNA. Oh, that's
It's coming from the tumor. You know, so I think we are able to look at these things and see also what is emerging over time. And when you are doing serial sampling, you could see the resistance mechanism emerge. And, you know, there's a lot of work in lung cancer. I didn't talk about EGFR, lots of resistance mechanisms, second and third line treatments that work. In colorectal, similarly, we now have mutation-specific drugs that some are approved, like G12C cancers of the lung. We're just going to be seeing more and more of this type of precision medicine, and liquid biopsy is one of the tools, one of the enabling features. And really, there's just so much more than the DNA that we still, you know, need to figure out how to use better.
Yeah. So if I understand correctly, you know, as you're monitoring the patient, and let's say initially their, you know, mutations went down, or their amount of ctDNA went down, but if it starts to go back up, that might be a transition point to say, okay, maybe we'll switch therapy to a different type of therapy.
Yeah, well, so I think it depends on the exact situation. I think like with any other tumor marker, it starts to give you a heads up. You know, if, for example, in my clinic, I typically would image every 3 months. If I saw a tumor marker going up, I'd do it every 2 months. And guess what? You know, the better we are at figuring out progression earlier, that just gives the patient more time to try other treatments that may be helpful to them, whether it's clinical trials or something that could be picked up by these tests.
Thank you.
Does anyone else have a question?
I do have one more question for the screen using ctDNA or liquid biopsies for screening. If I understood the chart correctly, it's a lot more effective for stage 3 and 4, not as sensitive for stage 1 and 2.
Yes, so not that we need all that much help for stage 4, the diagnosis. But I'll tell you a story, you know, because it's fun to talk to you guys. Grail, this company that has this Galleria test, was started by a Google executive by the name of Jeff Huber, because his wife developed colon cancer that wasn't detected early, and she died. And a few years ago, when I was at Fox Chase, I was part of a panel that got to look at, you know, her case to try to come up with ways of helping her. And so, you know, it became his mission to do something about it. And if you focus on the early stage cancers, people walking around with no symptoms, there are currently, you know, no real routine screening blood tests, okay, to detect those cancers. And so if you look at the emerging data over the last few years, you've gone from close to 0 ways of detecting them. And we do have our regular screening, and I could tell you, I've seen plenty of patients with advanced disease who just aren't getting their screening. So that is a problem. But we've gone from close to 0 to, you know, maybe being able to detect 50% of early stage cancer. So that's a big deal, especially as, you know, it matures a little bit more and we figure out exactly what to do with it, or that there's more evidence in terms of those false positives and costs and everything else. But, you know, I mean, these tests are $1,000. Actually, it's less than $1,000 for the Galleria test. You know, it's not a bad thing. I mean, I think it's definitely worth looking at. And actually, the government, Joe Biden and the NCI are very interested in these tests. So I think our government is investing in looking at this in a large population base throughout the country, and we want to be doing things here in Rhode Island with them. And it's timely, you know, so I think it's a good opportunity, and I think they're going to be around for some time, and you know, may even prove to be useful.
Yeah, I think what really blew my mind about the Gale study was that it allowed for the detection of 50 types of cancers through that blood sample, whereas we only have screenings in our, you know, our PCP clinics for 5 types of cancers, really. But I guess my question for you, Dr. Aldiri, is since the Gale study was really focused on specificity rather than sensitivity, and there was that small percentage of populations that was detected to have a cancer, but wasn't able to find in the metrics which primary it was, who follows these patients? Is it followed by the PCP? Is it followed by oncology? I'm just curious what types of conversations are ongoing with how this new shift in screening patients, who might take ownership of that?
Yeah, those are really great questions. And let me take a crack at this. So I would say, you know, one other thing that you should be aware of, you know, so if you were to speak with Dr. Stephanie Graff, you know, she may tell you, you know, she may say, well, we'll have to see how this really plays out in breast cancer, because there are lesions and maybe you detect things, and, you know, what does it really mean to detect, you know, a stage 1 where maybe the natural history just was never gonna matter as far as survival. So there is that issue of sort of over-diagnosing early stage cancers where, you know, do you really, I mean, we all know lots of people die with prostate cancer than of prostate cancer. So that's yet another example. But clearly, you know, when prostate cancer progresses, it's not a good thing and it can be horrible. Now, with respect to your other question about who is administering these tests, who's interpreting them, who's following, who's taking care of the patients, believe it or not, it's a little bit like the Wild West right now of people trying to kind of carve it out somehow. And who knows, you know, maybe there'll be a new specialty, but there is this idea that these tests will typically be done in primary care clinic. And then what happens after that, you know, if a test comes back positive, will there be a group of oncologists who will then want to be looking and interpreting and figuring out what to do with these tests? You know, in the field of oncology, sometimes some oncologists will decide to see patients if they have a diagnosis of cancer. But clearly, there are oncologists who will start to follow patients before they have a diagnosis of cancer. And, you know, where there's money to be made, somebody's going to find a way of bringing it into the practice and maybe starting a clinic or something along those lines. But there are other specialties out there that have relevant expertise. You know, including genetic counselors, although they tend to be much more interested in germline changes than, you know, sort of the things we are talking about. But it's definitely evolving, and actually, you know, you pointed to sort of suspicion of cancer, but indeterminate in terms of what type of cancer. And, I don't think that has been really addressed, but what I would say is that they should be followed by someone. Like, I mean, I would be the type of person who would like dig into what is going on here. And, there are tests obviously out there, cancer of unknown primary, and you can argue about whether there even is such a thing, because ultimately all cancer comes from somewhere, and it does have a primary, but sometimes you just have a hard time finding it. But with better and better molecular tests, some would argue that there's less and less cancer of unknown primary. It's just that you didn't do the right test to figure out where it came from.
Thank you.
All right, thank you very much. Good luck with the rest of your course. It was fun spending time with you.
Thank you.
Thank you.